Alrighty, week 9, bladder renal disorders. Kidneys and bladder. And going straight to urinary. So, voiding dysfunction, incontinence is not a normal part of aging, and it is any involuntary loss of urine through the sphincter? I think sphincter. There's a sphincter down there somewhere. So incontinence can come about from medication, surgery, infection, constipation. It can also be as a specific classification as functional loss, in that it is basically a person's inability to really access the bathroom in time. So with the elderly, they have an increased risk of functional loss due to the fact that it takes longer for them to get around from where they were when they felt the urge to the bathroom. That is a more functional or normal part of aging. Access issues could be a problem, such as someone who is paralyzed, wheelchair bound, or if they have a nervous system pathology, such as loss of control around the bladder, such as with a spinal cord injury. So there are three kinds of chronic incontinence. There is the overflow incontinence, where we have something like a benign prostatic BPH hyperplasia, or perhaps there's I don't know, something else. And the bladder fills up a lot, ends up stretching the outside. I think this also can come from when a person adapts their bladder to holding a lot more urine than they should. That can promote a kind of closure, I guess, down there. I don't know, I read something about that in the book. And the bladder is unable then, because of that, because the muscle's been stretched or because there's a blockage down there, to really fully empty properly. Stress incontinence comes from the idea that there is a lot of stress from the abdominal cavity compressing the bladder from all sides. So this comes from people who are overweight, or if you're pregnant, or you have a tumor growing in there, and just comes from that increased abdominal pressure. Sometimes if the person is maybe a weightlifter and they have a really heavy squat, then that can release or manifest as a stress incontinence during that moment that they are really maxing out. Urge incontinence is going to be where the filling of it is normal, the bladder wall is relatively normal, the urethra is not blocked, but there is a problem with the bladder itself being overly sensitive to any stimulation from the amount of urine that goes in there. It can also be due to a neurological disorder, like we mentioned earlier with functional loss, where if a person has, say, a spinal cord injury, they don't have any more, no, what was that? I think that was right. Maybe not, because you wouldn't feel that. Well, all right, so regardless, some neurological disorders can result in this, where there's an increased urge and oversensitivity of the bladder, feeling like you need to go right now. So functional incontinence, again, is related to physical or environmental limitations. You just can't get there in time. So the overall treatment of this is that we have, if it's going to be stress incontinence due to weight, then we can promote weight loss. We can decrease caffeine intake, because caffeine and diuretics in general help to make us need to pee. Avoidant constipation. I don't understand why constipation makes you need to pee more, but supposedly it does. There's some evidence to indicate that pelvic floor muscle training can be helpful, like doing Kegels, but it seems to be a controversial perspective. Bladder training is seen to be a more worthwhile endeavor, in that you have like a clear schedule that you follow. Maybe every 2 hours, every 3 hours, you just simply go, you try to go to ensure that you don't have any accidents. You can also try some surgical options where you tighten up parts of the bladder or the sphincters down the urethra, and then certain medications can be helpful, such as anticholinergic agents, which are known for promoting urinary retention, and then estrogen I don't actually understand why estrogen, but that's okay. I'm not going to need that anymore. Um, yeah, so estrogen is also a possibility. Enuresis is going to be, remember the term because it's just going to be a term for you to remember, is intermittent incontinence while asleep, and typically occurs with children, or if you happen to have a hand in a cup of water. I'm not sure if anyone ever does that anymore, but supposedly that works. Vesicoureteral reflux. So this is going to be either a primary condition or a secondary condition. Primary, you're pretty much born with it. Secondary can come from increased pressure in the abdominal cavity or from injury. There is some sort of incompetent valve at the ureter bladder junction, so like right in this area here. The urine will reflux from the bladder up the ureter, which there's none here. In this here we have the urine. There's a faulty valve here, and it starts to travel up. Right here, it's only about there. And so there are 5 grades. So this is going to be our normal bladder and kidney and ureter. Grade 1 has urine starting to go up the ureter, but there's no dilation. It hasn't reached the kidney yet. Not really that big of a deal. Grade 2, we see that the urine has filled the entire ureter up to the kidney, but there's still no dilation yet. Grade 3 is going to be that it has all of the previous, and the ureter has had some mild dilation. Grade 4 is going to be where we have moderate dilation of the ureter, and then grade 5 is where we're going to have significant dilation of the ureter, just like really just massive amounts of dilation. And that refluxed urine can act as a medium for bacterial growth, and that can lead to pyelonephritis, which is going to be inflammation of the parenchyma inside the kidney. So these people are at very high risk for recurrent UTIs because that that urine is a great medium for bacterial growth. Avoiding dysfunction. If you're not going to have that valve working well, you're going to have some problems letting it all out. Renal insufficiency or hypertension in children. So bolded. So vesicoureteral reflux has the potential to have hypertension in children. Adults are more capable of managing the results of an episode of vesicoureteral reflux. Children are going to be more susceptible to developing hypertension from the perspective that they can't release the water through their kidneys, out their bladder as urine, and maintain their blood pressure that way. The symptom may resolve on its own spontaneously, or it may require surgery to fix that faulty valve. So urinary retention is going to be the general inability to completely or partially empty the bladder, leading to urinary stasis, which is a very high risk for bacterial infections and UTIs. So stones blocking the exit through the bladder are a possible etiology, as are medications, structural, like, for example, anticholinergic medications. Structural abnormalities and voiding dysfunctions can cause urinary retention. Cystitis is going to be where that urinary retention or anything else leads to a bladder lining inflammation, or realistically just a lower UTI. So that's what cystitis really is a lower urinary tract infection. So we have a urethral infection, or we can have a bladder infection, and chemical irritants can be one of the causes for that. Females are at a higher risk for it than males because they have a shorter urethra, less of an area to really kind of control the ascent of bacteria. Increased age is going to be a risk factor to the fact that they are not going to have as good of an immune system. Catheterization, because you're literally shoving something up that urethra and having a host of potential exposures to microbes. Diabetes mellitus, poor hygiene, don't wipe from back to front, wipe from front to back. and urinary stasis, because it's a breeding ground for bacteria, and sexually active females, because y'all just seem to get the short end of the stick with everything. UTIs, as just UTIs, not cystitis, but UTIs, is sort of like a catchphrase for both cystitis, which is going to be the infection, inflammation of the bladder and the urethra, and then also pyelonephritis, which is going to be the inflammation, infection of the ureters and/or the bladder. I'm not the bladder, and/or the kidneys. So you can have an infection that starts as cystitis, a UTI that starts as cystitis, and then travels up and becomes pyelonephritis and cystitis. So with cystitis in the bladder, we're talking about symptoms like frequency, urgency, burning, cloudy urine, because it's all based off of the bladder itself. With pyelonephritis, we're talking about having it start way up here instead, on the backside, so we're going to get flank pain, still dysuria as well, pain at that costovertebral angle, CVA, and then otherwise the same signs and symptoms as cystitis. Kids are going to present with they're both going to present pretty much the same general presentation. Infants are going to have, and kids are going to have more of a fever presentation rather than the elderly. The elderly have a weak immune system, and so they're not going to necessarily present with a strong fever response. We're going to be going more off of confusion and altered mental status. So benign prostatic hyperplasia. This is a very common, very common disorder that comes about with age for men. 80% of men over the age of 60 are likely to have it. I think it was also 50% of men, those over 50, something. They think that it might have something to do with hormones. And this is where we have the prostatic tissue increasing in size and compressing then the urethra and the bladder outlet, leading to problems in the bladder, problems with fully releasing, and problems with sexual function as well. It's also, I think, a risk factor for prostate cancer. At the time, it's benign, but I think it's also still, just because it's inflamed, don't take my word for it. So people, remember the acronym FUN as manifestations of BPH, high level of frequency, high level of urgency, as well as nocturia. They may have hematuria from blood in the prostate gland. They're at an increased risk of infections. They'll have decreased stream and increased residual urine in their penis and the bladder, which is stasis. Yeah, okay. Already went with all that. Kidney problems. Okay, so acute kidney injury used to be called acute kidney failure. Now it's called AKI. And it is related to an abrupt insult to the kidney that causes a rapid decrease in renal filtration function. So something happens to the kidney, anything. And because of that, the kidney no longer has its full renal filtration function, and it's a definite, significant decrease in what it should be. And that leads to an accumulation of nitrogenous waste products in the body. And those are, because they're, by given name, a waste product, they are needing to be they need to be removed from the body because they are toxic. There are a broad spectrum of kidney diseases that can create acute kidney injury, and it's generally considered reversible, though it normally takes about 2 to 3 weeks to really recover from it after the precipitating event. So the etiology for AKI can be really split up into pre-renal, intrinsic or intrarenal, and post-renal causes. The 60% of cases are pre-renal, having to do with ischemia, or a decrease of blood volume. The kidneys really rely on blood pressure and blood volume to function. If they don't, stuff inside starts to break down, They start to make clogs in the tubules, and stuff just gets all sorts of wonky. It's just bad. Um, and the majority of cases, 60%, are due to pre-renal causes. Intrinsic or intrarenal causes come from toxins, immune disorders, infections, as well as intratubular obstructions. So toxins include things like NSAIDs, aminoglycoside antibiotics, radiopaque or PAC dye used in imaging. Infections can come from glomerulonephritis, pyelonephritis. Those can all cause AKI. Internal obstructions can be things like if you have a really high concentration of, say, hemolytic, after having hemolytic disorders, byproducts from red blood cell breakdown. They are super high concentrations in the blood. They go through the glomerulus, and they end up clogging up the tubules of the kidney. So that would be an internal obstruction. And then we have our post-renal problems, where really it just has to do with some sort of an obstruction of the urine outflow from the kidney. 5% of cases are going to be due to post-renal obstructions, such as nephrolithiasis, a fancy way of saying kidney stones, and a BPH. So again, we've got our AKI, which can be divided up into pre-renal, post-renal, and intrinsic or internal. We talked about glomerulonephritis. We are going to, so acute interstitial nephritis is really just an allergic reaction. And then we will also talk in a bit about acute tubular necrosis as being one of the causes of intrinsic acute renal failure. So hypotension, decreased cardiac output, decreased volume, all of those easily lead to pre-renal failure. And so, I mean, you can see exactly why it is that those make up 60 to 70% of all the acute kidney injuries. So again, this is abrupt reduction in renal function, leading to an accumulation of waste products in the blood. Clinical manifestations are going to include a decrease in glomerular filtration rate and oliguria, leading to then hypervolemia and hypertension. So people may have facial edema, pulmonary edema from this. The kidneys are also going to retain a lot of nitrogenous waste products. So we're going to see an increase in BUN, an increase in serum creatinine, and this is going to result in things like metabolic acidosis due to the lack of excreting acids and a lack of creating bicarbonate, just due to the fact that the kidneys are all sorts of funky. So they may end up with confusion, coma, all the things that have come about with metabolic acidosis and encephalopathy. I think the idea of thrombocytopenia and anemia comes from the idea that with more long-standing acute kidney injuries, we are not going to be able to produce erythropoietin, which comes from the kidneys, and so we're not going to have the base building blocks needed to create red blood cells, white blood cells, and platelets. So we're going to be at risk for bruising, fatigue, palpitations, all that. Eventually, we're likely to have large diuresis from the perspective that a lot of the parts of the kidney are going to degrade away. The filter is going to become a lot wider, and you would think that this would be a good thing, but we're actually kind of purging everything indiscriminately through the urine with this large diuresis. We will see alterations in lab tests in the blood and urine. We will see azotemia and uremia, with azotemia being a fancy way of saying BUN, higher BUN levels than we should have in the blood, and actually urine in the blood as uremia. You would think it'd be uric acid or urea, but it's actually urine. Creatinine, calculated GFR, all that stuff. We're going to be watching a lot of that. Acute tubular necrosis. So this is going to be the most common cause of AKI. I think that comes from the idea that, So it's the most common cause of AKI from the perspective that it comes after ischemia. So we have, let's say, low blood pressure, low blood volume for whatever reason. We have ischemia to the kidney that leads to acute tubular necrosis. Um, this can be due to sepsis also, or contrast media, a number of reasons for why we have ischemia. So we end up having tubular damage because we have this over here breakdown of the endothelial tissue inside the tubules. So now we've got all of this down here, this cast down here, obstruction by casts, which is the shedding of that basement membrane, blocking all of this. Stuff's trying to come in through here, it's getting filtered through here, coming down, but bam, whammy, there's no real ability to get down here because we got a blockage. So we've got tubular injury, we've got tubular back leak, out through here, back out through here. We've got interstitial out in this area here, inflammation. And so all of this, we also have some vasoconstriction because of the idea that with less blood flow, anytime we have blood vessels that experience less blood flow, we're going to have them constrict because they're trying to shunt blood then to other areas of the vasculature. But if they all do it at the same time, holy crap, nothing's getting blood. All of that leads then to a decrease in GFR and any number of problems. So again, pre-renal, we're talking hypotension, hypovolemia, decreased cardiac output, just things in general that prevent the kidney from getting blood. Intrarenal, we have our infections, nephrotic syndrome, acute glomerulonephritis, which I think you guys are giving a presentation on. But in brief, acute glomerulonephritis, glomerulonephritis, 5 to 12-year-olds are the most common age range for this, and they're most commonly from after having had a strep throat that went systemic, didn't get treated well. We can have not only heart problems from what is it, type A, beta A, or no, the streptococcal infection in general. So strep throat, you can not only have the heart stuff, you can also have kidney problems and joint problems. Just get those friggin' strep throats taken care of, get the antibiotics. It can also come from rubella, mumps, Epstein-Barr, get your vaccinations. And in this situation, we have antigen-antibody complexes that damage the glomerulus, which is the initial filter that prevents things like proteins, red blood cells from entering into the kidney, into the tubules, allows things in like glucose, sodium, electrolytes, water, so that they can filter it out. And because of these antibodies damaging the glomerulus, it makes it super permeable. So now we actually do allow things like albumin and red blood cells into the urine. And it totally messes with the glomerular filtration, and actually we end up with a reduced level of glomerular filtration rate, but we're letting out a higher concentration now of albumin and red blood cells. So medications that would normally bind to albumin, making them less active in the body, are going to now have a much more potent effect. Patients are also not going to be able to necessarily breathe as well. They're going to have more confusion, lightheadedness, all that fun stuff. We already talked also about infection as an intrarenal acute kidney injury etiology. We have some protective mechanisms within the kidney to try to protect it from infection. So the pH of urine being acidic helps, as does the urea in the urine. Peeing out from the kidneys and the bladder helps because we are diluting and washing out the pathogens. And then for both men and women, we have urinary and reproductive secretions that are helpful in being either bacteriostatic for men or as providing a protective mucus in the urethra to keep things from being able to travel upwards and through to the tissues. Pyelonephritis is going to be inflammation of the renal parenchyma, so the tubules themselves, everything inside the kidney. A lot of times this comes from the ascending infection from the lower urinary tract, with E. coli being the most common organism. This comes from, say, urinary retention. Maybe we had a lot of water, started working on the floor, 12 hours goes by, and the entire time we're saying, nope, we got to hold it because we have patients and their needs to take care of. And 12 hours go by, and you've been holding your bladder the entire time, and suddenly now you have, a few days later, inflammation to the renal parenchyma. Vesicoureteral reflux is also a high risk for pyelonephritis. We can also develop pyelonephritis from urosepsis by way of a urinary infection that comes from the systemic source. So maybe an infection started somewhere else, traveled all the way to the kidneys, and now created a intrinsic infection. With pyelonephritis, as with a lot of things that cause inflammation in the kidneys, you're going to have a pain over the costovertebral angle, so you can put your hand flat on the back. Fingers are going to be over the spine, but you're not going to hit your fingers. You're going to hit the knuckles, the big knuckles on your hand, and that will give them some pain, which is not very ethical, but it helps us to determine what's going on. They'll have nausea and vomiting, fever, pain in the back, side, and groin. It'll also likely radiate to the side a bit. A strong urge to urinate, burning while urinating, blood in urine, pressure in the lower abdomen. Acute pyelonephritis can also result in acute kidney injury if they've had repeated or severe infections over time. Let's see here. So glomerulonephritis, which you talked about a little bit, big old holes opening up more so in the glomerulus. They shouldn't be doing that stuff. Nephrotic syndrome, as we just covered. Here, I swear to God, I covered it. Where was it? Or was I about to cover it? I was about to cover it. Oh, okay. So nephrotic syndrome is going to be protein loss, more than like about 3.5 or 3 grams of protein per day. Usually it's a lot lower than that. And nephritic syndrome, I don't think we covered that at all. This is going to be where we have an increase in blood loss through the urine. I guess that's all we have to know. So on to nephrotic syndrome. This is going to be any disorder that ends up leading to glomerular damage that causes 3.5 grams, 3 grams or more per day of protein lost in the urine. A lot of systemic issues can lead to nephrotic syndrome, such as diabetes mellitus, which is going to end up being the most common form or etiology of nephrotic syndrome. Lupus, infections, malignancies. A lot of these things will cause the glomerulus to become more permeable, similar to glomerulonephritis. And we have then proteinuria, protein in the urine, leading to hypoalbuminemia. So we're having all of our albumin leaving, which is not good also for the binding to drugs. That's going to end up leading to stimulating the hepatic synthesis of hyperlipidemia. And hyperlipidemia is going to exist because the liver is going to be trying to synthesize lipoproteins to replace the proteins that are leaving. But doing so is going to end up increasing the LDL tremendously, like a lot. The loss of serum proteins also will lead to a loss of antithrombin 3 and plasminogen, which are both thrombolytic substances, and that's going to increase the risk of thromboembolism or thromboemboli. So we don't have enough of the products that are needed to break down existing clots and clots that are developing. So they're at risk of throwing a clot, so they may need to be going on anticoagulants. I don't know how that relates to this guy here, but okay. With a hypoalbuminemia, we end up having a decrease in plasma oncotic pressure because the albumin created a lot of that, if not the entirety of oncotic pressure. We'll have then a decrease in cardiac volume output or circulating, and we're going to have a lot of generalized edema. That's also going to result in more fluid retention by stimulating RAS, leading to more sodium water retention, but it's not going to stay inside the blood vessels very well, which is what oncotic pressure does. And so we're going to end up with more fluid in the body in whole, but it's just kind of going everywhere indiscriminately. So treatment for nephrotic syndrome is going to be diuretics to get rid of a lot of that fluid, lipid-lowering agents because of this hyperlipidemia, antihypertensives because we're going to have a lot of fluid on there, immunosuppression and immunomodulation to try to, if it is a hyperactive sort of anti or immune system response, and manage the underlying disease if we can identify it. So if we're talking diabetes mellitus, we're going to want to try to treat that diabetes to get it to be better controlled. So this whole thing may resolve spontaneously if it wasn't a very significant nephrotic syndrome, but it may also end up progressing to end-stage renal disease if it goes on too long or if it's too severe. Post-renal acute kidney injuries normally come from things like nephrolithiasis or kidney stones. So obstructive uropathy is obstruction in the urinary tract. We can also have the potential of a neurogenic bladder due to loss of neurogenic bladder control, such as when you have MS or spinal cord injury. The most common etiologies for obstructive uropathy is going to be kidney stones, but we can also have other ideas such as tumors, prostatic hyperplasia, or a natural narrowing of the ureters or the urethra. When we have urine stasis from such things as obstructive uropathy, this is going to, again, as anything else, predispose the person to infection. This is the main thing, but also supposedly some structural damage. Nephrolithiasis is going to be which is the same thing we've been talking about. We can have either crystallization of the organic or inorganic materials in our body, leading to some really nasty things. It can be as little as these little guys here that kind of fall down and get through the ureter, or we can have these giant honkers that are just impossible. There's no way that's going down that hole. We got to operate. Or remove the entire thing. I have no idea what they would do in that case. The renal calculi exist in the first place because there is urinary supersaturation with a specific solute. So it can't just be like a bunch of different solutes that are not able to bind to each other very well. It's got to be specific solutes that will bind to each other and form crystallized forms of themselves. And we also need it to be supersaturated in that we are dehydrated or not having enough water. We want to saturate our bodies with water. Always drink lots of water. And having abnormal urine pH doesn't help the issue either. Most of the time, they're calcium-based when it comes to the renal stones. But they can also be uric acid or struvite, cysteine, or they can come from medication itself. Stay big. If they are stationary, simply stuck in here, they're not moving anywhere, generally they're going to be asymptomatic. If they get dislodged and are traveling down now the ureter, they're going to cause super intense pain. It's going to be abrupt. You can be like, oh my God, and you need to lie down and stay down. You're not going to be able to find a comfortable position. You're not going to be able to just simply pee it all out. You got to wait for it to kind of just settle down through the ureters and find its way out. You may have nausea and vomiting, diaphoresis, And then because of the trauma associated with having this super bloody, sharp thing going down your ureter, you may have hematuria. Most stones, luckily, do end up passing on their own, but if you've had them, you tend to have them recur, and they are very painful. The best way to treat this is to, or prevent it, is to make sure you're having plenty of fluid intake. No, wrong button. Plenty of fluid intake, and then maybe we need to change the diet to reduce the chances of having that supersaturation with a specific mineral. So if you have calcium-based stones, maybe not having as much cheese and dairy will help to reduce your chances of developing a renal calcium-based stone. If we have complete obstruction, this is going to be a high risk for infection. Hydronephrosis, which I think is what this is here, this super distended kidney and ureter. A decrease, of course, in glomerular filtration because there's no friggin' movement through here. Ischemia due to the increase in pressure, so all this backup here is going to prevent any further blood coming into the kidney, and so we're going to experience things like active tubular necrosis, leading potentially to chronic renal failure, the chronic kidney disease. Speaking of, chronic kidney disease used to be called chronic renal failure, that's why I said that, and can be caused by anything that can injure the kidney. Most common etiologies for chronic kidney disease are going to be long-term hypertension and diabetes mellitus, because there's a lot of sugar that comes in with diabetes mellitus, especially diabetes that's not well maintained, and all that sugar is just going to go straight through your kidneys. Overall, there is a progressive loss of functional nephrons over time. I could not figure out what this greater than 3 months was about. Maybe it's greater than 3 months is the time frame in which the kidney continues to go downhill. I don't know. Couldn't find it in the book. Couldn't find it online. Glomerular filtration rate, GFR, of less than 60 mils per minute is about grade 3 out of 6 or 5. And it indicates like mild chronic renal failure. All of that stuff, I'm not going to go into that. Risk factors for chronic kidney disease, again, diabetes, hypertension are very common. Recurrent pyelonephritis, glomerulonephritis are both also very common etiologies for chronic kidney disease. Having them over and over again, like anything else, you are constantly inflaming that tissue. That tissue is not going to be able to maintain itself over time, leading to chronic disease. It can potentially be hereditary or genetic based with a family history of chronic kidney disease. History of exposure to toxins, so if you've had a lot of imaging work done, radiopaque, then you're exposing your kidneys to a lot of toxins. Being older than 65 also is a distinct risk, and ethnicity. I'm not sure which ethnicities. I think maybe Caucasian might be a risk factor. So we are actually able to have compensation with this. The kidneys are incredibly resilient organs, and will be able to maintain themselves until, in total, they reach about 75 to 80% of non-functional nephrons, at which point we're going to start having symptoms. And we're going to continue having injury due to compensatory measures to help allow for the urine to pass through the kidneys. We're going to end up with proteinuria, an increase in serum creatinine, and an even further lowering of the glomerular filtration rate. Eventually, we're going to get then to end-stage renal disease. This is a complicated little diagram. Okay, yeah. And then end-stage renal disease is the last stage of chronic kidney disease. If you're lucky, it happened to only one kidney. Maybe you can take it out and you are able to live off the last one. but generally ESRD is simply the entire renal system, and you are either having to live on hemodialysis or just die, I guess. It is, but that sounds horrible to kind of leave people on as the last of this. So I'm just say that looks cute. Yeah, that looks cute. That's a good way to sign off.